Marianne, you can take it on now, can start. Then you call the RD.
Hello, everyone. I'm Marian Tabi, and welcome to the WHO Africa Media Briefing. Today, we will provide updates on ongoing public health issues in the region, including progress on immunization, malaria control, health emergencies, and polio eradication efforts. This briefing is available in French and English, so please select your preferred language by turning to the globe icon on the bottom right of your screen. Now, joining us from Brazzaville in the Republic of Congo is Dr. Mohamed Jadabi. He is the Regional Director for the WHO Regional Office for Africa. We also have here Dr. Marie-Roseline Belize, Regional Emergency Director, WHO African Region. Dr. Benito Impuma, Director, Health Promotion, Disease Prevention and Control Cluster. Dr. Adelaide Onyango, Director, Health System and Service Cluster. And Dr. Gedi Mohamed, Program Coordinator for the Polio Eradication Program. Dear friends of the press, this is the first time that we are having all our directors on board on the presser, and they will all be available to respond to your questions today. I will now invite Dr. Janabi to give us an update on the health priorities, progress, and challenges in the region. Over to you, Dr. Janabi.
Thank you, Tabi, our moderator today. Good morning, good afternoon, dear friends. Today, Africa takes the microphone, bringing facts, leadership, and accountability from Africa for Africa. This platform is about ownership, it's about transparency, and it's about placing African realities and African solutions clearly on the global health agenda. Today, I will cover 4 areas that matters deeply to our people and our future. Immunization in Africa, where progress has saved millions of lives, but momentum is slowing and too many children remain unprotected. Polio, where cases are declining and outbreaks are being stopped, yet our work is not finished. Stillbirths, a silent and devastating crisis that remains largely invisible despite being widely preventable. And health emergencies from cholera and diphtheria to yet undiagnosed illness in Burundi today, reminding us that vigilance, speed, and trust are non-negotiable. Ahead of African Vaccination Week, WHO Afro, together with Gavi, the Vaccine Alliance, is releasing the most comprehensive review ever conducted of immunization in the African region. It covers 24 years of data and is aligned with Immunization Agenda 2030. The progress is undeniable. Since 2000, nearly 20 million measles-related deaths have been prevented. More than 500 million African children have been protected through routine immunization. In 2024 alone, 1.9 million lives were saved, and malaria vaccines are now being introduced in 25 of our member state countries, a major scientific and public health breakthrough. But the report also issues a very clear warning. Progress is uneven, and in some places, really slowing. The COVID-19 pandemic increased the number of zero-dose children. That is, those children who have never received a single vaccine. Today, as I speak, 10 countries account for 80% of the zero-dose children in this region. This is a profound equity issue. A child's chance of survival must never depend on geography, conflict, or even climate shock. Immunization Agenda 2030 is very, very clear. Strengthen routine immunization as part of primary healthcare, PHC. Reach the hardest to reach communities. Sustain domestic financing and the political commitment, and a scale innovation from data systems to local manufacturing. Because prevention is not only better than cure, it is faster, fairer, and far, far, far affordable. Let me turn to polio. In 2025, detections of circulating variant poliovirus fell by 50%. The variant type 1 outbreak in Madagascar has been declared over. This reflects strong leadership and improved surveillance. It also, thanks to the courageous work of health workers, reaching children in the most difficult environments. But we cannot get comfortable. Variant type 2 poliovirus continues to circulate, affecting 20 countries over the past year. Our goal remains zero polio. Achieving that goal requires sustained investment in routine immunization, laboratories, surveillance, and rapid response. We are moving in the right direction. Now we must accelerate. I now turn to a crisis that is too often ignored or forgotten. Just a soft reminder, every 30 seconds, a baby is stillborn in the African region. Nearly 1 million babies are lost every year, almost half of the global burden. Africa's stillbirth rate is more than 40 times higher than the Europe's one. What makes this especially painful is the fact that up to 70% of these deaths are preventable. Half occur during labor in health facilities. The very places where women and families should be safest. We must end the silence around stillbirth. Every woman deserves skilled, supported care at the moment it matters most. And every loss must count, not as a statistic, but as a failure we commit to prevent. Finally, a brief overview of emergencies. Cholera outbreaks have declined from 23 to 14 countries, quite a progress, but flooding, displacement as well, weak water and sanitation continue to drive risk. Active diphtheria outbreaks have also reduced from 8 to 4 countries, that is 50%. The resurgence was a direct consequence of gaps in routine immunization. Today, as I speak in Burundi, health authorities supported by WHO are investigating a yet undiagnosed illness. It has so far caused 5 deaths, and 35 cases have been reported in a community in the north of Burundi. Initial tests have ruled out diseases including Ebola and Marburg. We have facilitated the shipments of samples to neighboring Democratic Republic of Congo, DRC, for additional tests. We are supporting disease surveillance, laboratory testing, clinical care, and rapid response efforts to identify the cause and halt potential spread, that is health security. This is all the information we have at this time. Emergencies are changing, but the fundamentals remain the same: detection, trust, speed, and coordination. Back to you, Marian.
Thank you so much, Dr. Janabi, for that broad overview on health issues in the region. Now that we've heard from Dr. Janabi, we will now open the floor for your questions. Please remember to use the Q&A function in the Zoom application to submit your questions. Remember, you have to introduce yourself and also the media organization you represent to have your questions answered. This also goes if you want to have a live question. We have received some pre-questions from journalists. We have a question, and this is coming to you, Dr. Benito Impuma, from RFI, from Christine Okelo. Le déploiement de vaccins antipaludiques progresse, mais reste dépendant des financements internationaux. Comment garantir sa pérennité en long terme? Over to you, Dr. Benito.
Merci beaucoup. C'est une question importante venant de RFI. Effectivement, la question de la pérennité des vaccins antipaludiques se pose au niveau de la région, mais il y a trois piliers qu'on devrait considérer. Le premier pilier, c'est le besoin de s'assurer que les vaccins antipaludiques sont intégrés dans les plans nationaux de lutte contre le paludisme que les pays élaborent. Le deuxième pilier qui est extrêmement important, c'est de s'assurer que lorsqu'il y a des cofinancements en matière de vaccination, on s'assure de la prédictabilité de ces cofinancements afin que les vaccins contre le palud soient pris en compte dans ce mécanisme de cofinancement qui se fait en général entre le bailleur et le pays. Et enfin, en matière de système de vaccination de routine, il serait extrêmement important d'intégrer les vaccins antipaludiques dans l'immunisation de routine pour s'assurer que tout vaccin, toute introduction de vaccin contre le paludisme peut atteindre les communautés les plus reculées, y compris celles qui ont ce que nous appelons les zéro dose children, les enfants qui n'ont jamais été vaccinés. L'un des points aussi qui est important à mentionner ici, c'est le fait que la vaccination contre le paludisme, comme l'a souligné le directeur régional, est un succès au niveau de cette région africaine. Environ une vingtaine de pays ont réussi à introduire le vaccin contre le paludisme au cours des 27 derniers mois, ce qui en soi est un succès énorme pour la région africaine. Merci.
Benito, it is now my understanding that Paul Adepochu wants to ask a live question. Paul, you have the floor, please. Paul, are you there? You can ask your question.
Yes, can you hear me loud and clear?
Yes, I can. Please go ahead.
Yes, thank you very much. So today we are talking about different health issues, but I'd like to know if we look at the overarching messaging around recent dynamics in the ecosystem and this revision of the immunization pipelines. I'd like to know whether these revisions, in addition to the scientific backings, are a reflection of the current realities in the public health funding landscape. So that's my first question. Then I also have a question for Dr. Onyago. And the WHO has always emphasized the oxygen as a system and not just equipment. And we saw its apparent impact during the COVID pandemic. But I'd like to know what has been done to ensure that these acquired capacities that we really invested a lot of money on during the COVID pandemic across African countries continue to deliver to patients that need them the most several years later. Thank you very much.
Thank you so much, Paul. Thank you for those questions. We will start on regarding the funding landscape. We will come to you, RD, Dr. Janabi, then we can go to Dr. Onyango. RD, over to you.
Can you specifically, the question had several parts, which part in particular?
The funding landscape, how is WHO coping given the various health priorities right now?
Yeah, if I understood the question well, let me cite examples for the past 1 year after all these geographical crises, financial crises, 40% of ODA going down. I think Africa is really showed resilience because that's the whole idea. Now, let me cite real examples. What has happened this past 1 year? We managed to control Ebola last year in Democratic Republic of Congo in a record time of 3 months. using the surge teams in DRC Congo, which we just went there to complement. We managed to control Marburg in Ethiopia with the same approach of us working together to avoid fragmentation, to avoid duplication, and effectively, because the funds have gone down, we managed to eliminate diphtheria and measles in Mauritius, Seychelles, and Cape Verde. We succeeded in pool procurement in the seed countries, which has made prescriptions to be more affordable and accessible at the right time. And the examples that we have seen the commitments from member states about local manufacturing, which is in process. We're just trying to coordinate, so it's done in a planned manner with the 24 items which AMA has suggested. So the coping mechanism is really wide, is a topic of the whole day. But the big thing is sovereignty. We have the global health architecture, which we have just signed in One Health approach in Lyon with Accra Reset, which WHO is supporting it very much. So there are multiple ways which we are trying to adapt and cope, because end of the day, the solution has to be African. Thank you.
Thank you, Dr. Janabi. Thank you so much. Paul, on your question on oxygen, will you mind repeating that again? I know you directed it to Dr. Nyango, but please, if you don't mind, you can take the floor and ask the question again.
Yes, thank you very much. I'm happy to take the question again. So, as one of the emergency response measures during the COVID pandemic, oxygen access was identified as a major problem in several African countries, and a lot of funds were pumped into supporting a lot of African countries to expand their oxygen access capacity. But a Lancet report last year showed that a lot of these, several of these investments, let's just put it that we are not getting the best out of it and not as fully functional as they expected to be. Meanwhile, other emergency responses like testing capacity, genomic capacities are being expanded to support other responses. So I'd like to know what is being done to reinforce the strength and the durability and the effectiveness and efficacy and improving access to oxygen, so that we get the best out of the investments in expanding oxygen access, especially during the COVID pandemic and now.
Thank you so much, Paul. I will direct that question to RED, the Regional Emergency Director, Dr. Marie-Roseline.
Thank you. Good morning. And this is a very interesting question indeed. So we know that during the COVID-19, one of the major issues in health emergency response when access to oxygen, where so many countries in Africa didn't even have, a plant of oxygen, or they didn't even have, oxygen concentrator in the countries. So far, after the COVID-19, a group has been putting in place at a global level where we are assessing the access to oxygen in the countries. We have so many countries that have been putting in place oxygen plant. I can give example. For example, in DRC, oxygen plant has been putting in place. In Republic Central Africa, also WHO has been supporting putting in place an oxygen plant with capacity of more than 200 bonbon a day. But that has also been a wide call for other partners to support. We have seen a lot of initiative in other countries where oxygen is being putting in place. We have also countries that have developed new facilities for hospital where they include that oxygen plant inside, so the oxygen can be distributed. So far, I don't have the exact number of countries that have been implemented that project so far, but it is to ensure that in WHO we take it seriously. And we are also reinforcing what we call the PIP, the Program of Influenza a global influenza program where it is one of the highest pathogens to cause in a respiratory disease pandemic. And we are also reinforcing them. So far in Africa, we have 11 countries that have benefited from funding this year and that will continue implementing. But it is not only because of I can say oxygen. We are also reinforcing surveillance so we can detect early, so we don't need to go to the use of oxygen. We are also reinforcing laboratories, and we are also reinforcing sentinel surveillance because this kind of disease, we put in place the sentinel surveillance in the country. So I have also to mention that this surveillance is important, not only for Africa, but globally, because this is that surveillance that inform the type of vaccine for influenza that we need in the subsequent years to come. So this is more or less what in the African region, that how we are supporting the member state to deal with after the COVID-19. Over to you.
Thank you, Dr. Marie-Roselyn Belize. I will also move this question to you, Dr. Onyango, in terms of health system strengthening. Over to you, Doc.
Thank you very much. A truly important question, and comes from a time when we realized that necessity is the mother of invention, because we didn't have much oxygen production in the region. And because of COVID, countries, including small countries like Liberia, were able to set up those plants and are, working really hard to maintain them. We also recognize that when there's a regional hub, so for example, the oxygen producing plant in South Africa, it makes that commodity available across the region. So as a health system strengthening, we don't just produce for one country, but we're looking at how those hubs and centers of production can actually supply, plus a mushrooming of other centers that are coming up in Ethiopia, Kenya, Nigeria, to expand the production of this very critical health product. Thank you.
Thank you so much, Dr. Onyango. We are going to, we have a question, I think, from Shisia Walsiwa from Deutsche Welle. And the question goes, despite decades of global funding and WHO-led immunization campaigns, why are we still seeing persistent immunization gaps in parts of Africa? And what specific accountability mechanisms will WHO implement to ensure that countries with low coverage are held measurable, time-bound improvements, targets rather than voluntary commitments? We will start with you, Dr. Benito.
Yeah, thank you. I think as far as immunization is concerned in this region, one of the things we need to acknowledge here is the great progress made in that area. RD mentioned 3 countries for the first time in history in this continent that managed to achieve measles and rubella elimination. These are Cape Verde, Seychelles, and Mauritius. We've also seen countries eliminating maternal and neonatal tetanus. So there are quite great strides which have been made over the past few years. It's true that we are still facing a number of challenges as far as immunization is concerned, one of them being the funding for immunization. But work is going on to ensure that countries can increase their domestic investment for immunization. One of the commitments which was made by countries is what we call the Addis Ababa Declaration on Immunization, where in 2017, heads of state committed to increase the financial contribution to immunization. We have also seen, as part of COVID-19 response in this region, the critical role of immunization. In fact, many of our countries were able to quickly detect COVID-19 as a result of significant investment in health overall. as far as vaccine is concerned, COVID-19 vaccines, we've been able, despite some of the challenges, to roll out vaccines across all member states who experienced COVID-19. Advocacy efforts continues with our heads of state, ministers of health, partners to ensure that not only country can increase their domestic financing, but also partners such as Gavi can continue contributing to the financing of immunization. Thank you.
Thank you so much, Dr. Benito. It is now my understanding that we have a live question. Julian Chogwan, please go ahead with your questions.
Oui, bonjour. Bonjour à tout le monde. Alors, ma question
Bonjour.
s'adresse à tout le panel. Je ne sais pas qui va se sentir le plus concerné. En fait, ma préoccupation, c'est que j'ai remarqué que dans les programmes de l'Organisation mondiale de la santé, notamment en Afrique, on parle très peu de la fièvre typhoïde. Or, vivant en Afrique, je constate que la fièvre typhoïde est l'une des maladies pour lesquelles les populations vont le plus souvent à l'hôpital. Alors moi, je voudrais comprendre quelle est la place que l'OMS Afrique réserve à la fièvre typhoïde et surtout pourquoi est-ce qu'on en parle si peu dans les programmes officiels de l'Organisation mondiale de la santé en Afrique. Merci.
Merci beaucoup, Julien. On va, Dr. Benito, on passe la question à vous.
Merci beaucoup. Je pense que la fièvre typhoïde, comme vous avez su bien le dire, est un problème majeur de santé publique au niveau de cette région. L'OMS, au niveau de l'Afrique, couvre énormément de maladies infectieuses et la fièvre typhoïde est l'une des maladies, effectivement, qui mérite une attention assez particulière. Il y a une stratégie régionale de lutte contre la fièvre typhoïde qui est en cours d'élaboration. Nous allons également, en tant que OMS, saisir l'opportunité de la réunion de l'ensemble des ministres de la Santé qui se tiendra à Addis Abeba d'ici la fin de mois de août, début septembre, pour s'assurer que cette thématique est discutée au niveau de cette réunion. Il est effectivement important pour l'Organisation mondiale de la santé, mais aussi les pays, de faire un long plaidoyer en faveur d'un certain nombre de maladies qui n'ont pas forcément l'attention qu'elles méritent. Ce genre de réunion au cours de laquelle nous réunissons le directeur régional, le management du bureau régional de l'OMS est aussi une opportunité de porter à l'attention des médias, à l'attention au niveau international de certaines préoccupations, de certaines maladies qui nécessitent non seulement le plaidoyer, mais aussi la mobilisation des ressources qui sont tant requises pour faire en sorte qu'on arrive à contrôler ces maladies-là. Merci.
Merci beaucoup, Dr. Benito. We are moving on to a question from Farai Mutsaka from the Associated Press. To what extent and how are funding cuts by US and other donor countries affecting progress? We do know that progress is uneven and even slowing in some places. Which places are we recording a slowing down and why? We will start with you, Dr. Janabi, then Dr. Onyango can complement. Over to you, Dr. Janabi.
Yeah, thank you, Tabi, and thank you, the reporter, for asking that good question. And let me try to incorporate my response with the previous question about immunization. Definitely, when our biggest donor, beginning of last year, actually around February, pulled out from membership. the ODA going down by 40%. It really disrupted the progress which was made in a number of key areas in Africa. So despite, if you take immunization, despite the really progress, immunization gaps persisted in Africa, because today the challenge is less about vaccine, it's more about equity and system. So if you take the COVID-19 disrupted routine services and recovery has not been even, especially for the most vulnerable communities. Too many children still remain at zero dose, concentrated in fragile settings, conflict-affected areas, and urban slums and remote community areas. So if you try to look back up to January of 2025, most of our major programs, TB, malaria, HIV, AIDS, they were in the vertical programs, which were kind of projects which depended entirely on funding from overseas. So with the sudden cut of all these funds, disruption really occurred. But what did the member states do? And we as an organization, plus other CDC Africa, UNICEF, and UNAIDS and other, what did it do? The first quick response was, we need here domestic financing. We need the health sovereignty. Can we integrate everything to the primary healthcare? And this is where WHO Afro, with our 4 pillars of primary healthcare, a stronger resilience, modernization, and sovereignty took place. So I think the continent reacted effectively, and that's why last year, I can cite you an example. We had 114 outbreaks recorded by WHO. So it's true, we have been affected, but I think it's an opportunity for Africa to reset. That's why all these initiatives are coming up now. The Global Health Architecture, the UNAT, the Accra Reset. And I believe strongly, and Afro believes strongly, our biggest rescue here will be investing on primary healthcare, because all these outbreaks, all these crises, they start in the community and they end up in the community. So if we can build the trust, we can invest in more community health workers who are really forefront, because they are the ones living with the community. Early response, our regional director for emergencies here touch it. The earlier we respond, we don't only save lives, even it's economic effective, because you tend to spend less. Back to you, moderator.
Thank you, Dr. Janabi. I will call Dr. Benito to weigh in on why progress on immunization is uneven in countries. I think a follow-up question is, there are 8 countries that have 0 dose, that have recorded 0 dose. Why? What are these countries and why? Over to you, Dr. Benito.
Yeah, indeed, we have 8 countries which accounts for the highest number of 0 dose. But one needs to know, across the world, there are 20 countries with high 0 dose numbers, and WHO in the African region has 8 countries. What we are trying to do right now is to, first of all, acknowledge the fact that 0 dose is a sign of an issue with equity in immunization, which we need to address. It's also a human right, because it's not just acceptable in the 21st century to have children who are not able to receive even the basic vaccines. So one of the things WHO has been doing, working closely with member states, is first of all to know where are these 0 dose children, where do they live, what are their characteristics, and what can be done to reach them. So we've been closely working with these countries to ensure that it's not just an issue around vaccine access, but it's also an issue around health systems. In fact, one needs to have enough resources, be it in terms of funding, workforce, to ensure that even at the most hard-to-reach areas, we are able to reach those children. So this is one of the areas where WHO has been very active when it comes, for instance, to campaigns, even after COVID-19, what we call the Big Catch-up program, which contributed to reaching some of the hard-to-reach zero-dose children. So it's work in progress. We acknowledge that issue, but we are closely working with government to ensure that as time goes on, we can ensure that we significantly reduce the number of zero-dose children in this continent. Thank you.
Yeah,
Thank you
and
so
Tabi,
much.
if I just have to top up what Dr. Benito has just said, closing the remaining gaps requires a stronger primary healthcare, targeted strategies for these zero-dose children, a very resilient delivery system, and sustained domestic and partner investment, because this is the focus of WHO Afro today, as we accelerate immunization agenda of 2030, leaving no child behind.
Thank you so much, Dr. Janabi and Dr. Benito, for those response. I will now pass this next question to you, Dr. Onyango, and it is coming from Millicent Kubai from Kenya Broadcasting Corporation. African countries, Kenya to be precise, are working towards having some vaccines produced locally to mitigate high cost and sometimes the absence of some vaccines. What is WHO doing to help countries in these efforts? Over to you, Dr. Onyango.
Yeah, thank you very much. That's a pertinent question, considering that we only, at this point, we produce only about 1% of the vaccines that we need in the region. So as we realized from the COVID-19, we couldn't rely on those long supply chains. We need to have production as close as possible to us in the region. So WHO is working very closely with the member states, because the member states, in fact, are asking for this. They want to increase their manufacturing sovereignty. And so we're working on, for example, identifying, first of all, we have done a mapping of the production capacity, manufacturing capacity on the continent. We're developing profiles that are going to help us to see who has what capabilities in manufacturing, whether it be vaccines or other medical products and tools. And then on the basis of that, we're looking then at the landscape to understand, if we're going to do manufacturing, is it everybody that has the capacity for manufacturing vaccines, or should we should diversify so that there is both the production and the market for it that is coordinated. Along with that, we have to build a whole ecosystem around that, around the manufacturing. And that is strengthening the regulatory systems to ensure that when the time comes for the manufacture of these vaccines, they're done, they're high quality, the standards are maintained so that we are not producing substandard products. We are also working very closely with other institutions on the continent, and with the establishment of the African Medicines Agency, we are collaborating very closely on ensuring that this key institution is built up and given the mandates and authority to be able to coordinate both the manufacturing of vaccines and the control and regulation of that and other products around the continent. So it's a work that needs time. We can't go from less than 1% to the 50 or 40% that is the ambition, but we have to work towards it, and we have to build a whole ecosystem. And that's why we're working very closely with every country that is putting forward a proposal, a desire to venture into medicines production, vaccine production, etc.
Thank you so much, Dr. Onyango. We have our next question from Lichuma from Citizen TV. And her question is, if immunization is still going on, why are still outbreaks in several African countries, such as cholera and polio? We will move this question to you, Dr. Marie-Roseline Belize.
Thank you. It is a very interesting question. So why are we still having outbreaks while we have immunization ongoing? So first of all, we have to understand we have different types of immunization. We have active immunization, what we do when we have an emergency. For example, cholera is not being treated as a routine immunization that is, involved in the primary healthcare. Most of the time, we have active immunization when we have a response and we put that immunization in place. But when we look at a vaccine preventable disease, to not have, for example, outbreak of that disease, the population or the country should have a rate of vaccination that should be over 90% of the population vaccinated by that. It is how they can create what we call herd immunity threshold. When we look at, for example, for measles, the herd immunity threshold is 95%. That means 95% of the susceptible population to get that disease should have been vaccinated against measles. When you look at the rate of vaccination in all the countries in Africa, we have very few that have that rate. If you look at, for example, at the Central African countries, when you look at Central Africa, Central African Republic, for example, the vaccination rate is 40%. So this is very far from what the threshold we need in order to prevent those outbreaks, So, and then when you look at also with the COVID-19, that put an interruption in the chain of vaccination in so many countries. Reason why now we are having diphtheria, for example, that has been a disease under control, but now we are having countries, and measles also is one of those diseases that we're still having those outbreaks after COVID, but even before, because the vaccination rate was so low, so the population didn't have the immunity you have. So when we look at what is the herd immunity, is that a number of population that are vaccinated. So even one person in the community has the disease, it will not be able to transfer or transmit that disease to other people in the community. So the disease will stay with one person. It's also important to understand the rate of transmission of the disease. Measles is one of the diseases with the highest rate of transmission. One infected people of measles can transmit the disease to 18%. So it's the reason why also WHO, we are really supporting the member state, not only to vaccinate, but also in outbreak is not only the vaccination the vaccination is a tool that we also use during outbreak, but we still have the prevention control infection that is really important. So how quick we are isolated those patients that are affected by those diseases. We also have the access to health care, which is a very important pillar when you have that outbreak. We also have the community protection, which is extremely important. How we communicate with the community in order to protect themselves, to know about the risk, to prevent them when they see people with a measles or with cholera. So they know what to do, they know how to isolate it, and they know where is the primary health care more accessible to them so they can go. So I will stop there, and maybe my colleagues can complete on the reason why we're still having outbreaks.
Yeah, if I may touch, Tabi, vaccines are powerful, but they are not magic. This thing has to be very clear. We continue to see outbreaks of cholera and polio because vaccines cannot overcome weak systems, poor living conditions, fragile access of care. So cholera outbreaks persist primarily because the disease is driven by lack of safe water, by sanitation, by hygiene. This is what we call WASH. So in many parts of the region, only a minority of people have access to safely manage sanitation and basic hygiene. So even when oral cholera vaccines are used, outbreaks will recur during floodings. We see rainy season in most part of Africa now, displacement. So poor wash conditions continue to expose our communities to contaminated water. So this is clearly documented in our documents of WHO, Afro, and Africa CDC in cholera preparedness reports, which we would be more than happy to share with our journalists. Polio persists for different reasons. The African region is free of wild polio. We all know this, but we still see outbreaks of variant poliovirus where routine immunization coverage is low. So the viruses are mainly affect children who are completely or partially unvaccinated. Often we see it in a very conflict affected or hard to reach areas. So weak surveillance, if I have to finish, population movements and cross-border transmission allow the virus to circulate despite the availability of all these effective vaccines. Thank you. Back to you, Tabi.
Thank you so much, Dr. Janabi. We now have our next question from Joy FM in Accra, Ghana. With frequent cross-border movement in West Africa, how vulnerable are countries like Ghana to polio resurgence and other outbreak threats? And what urgent surveillance measures are needed now? And this question is coming to you, Dr. Gedi Mohamed. Over.
Thank you very much, Tabi. Maybe I will start by saying that as long as polio is anywhere, the risk remains everywhere. And also polio, like other pathogens, know no borders. Countries like Ghana remain vulnerable to polio resurgence and other outbreaks due to frequent population movement from affected countries, which can enable the viruses to spread undetected, especially where immunity gaps persist in border and hard to reach communities. Therefore, strengthening surveillance, routine immunization is urgent. This means there is also need for closer cross-border coordination and real-time data sharing between countries in the region. Expanding also environmental surveillance in high-risk districts such as the border towns and urban hubs, while ensuring rapid detection and laboratory confirmation is key. And that's why in this context, the recent opening of the Ghana's restructured National Polio Reference Lab in Africa is to enhance sequencing capacity and rapid detection of cases. Thank you very much. And also maybe to complement on the previous question, where we have polio in the Lake Chad Basin countries, Eastern DRC, and as well as the Horn of Africa, and even beyond the African region in Pakistan and Afghanistan and Yemen. These are areas that have a lot of fragility in access, issues of health system, and reaching the children, even when the vaccines are available, is really challenging. But even with those challenges, Africa has demonstrated previously and is wild polio free for several countries now. Thank you very much.
Many thanks, Dr. Gedi Mohamed, for that response. We do have our next question still from RFE, from Christine Okelo, and she's referring to the immunization report that was released today. L'analyse montre des progrès dans la couverture vaccinale des enfants n'ayant reçu aucune dose et quelles sont les principales priorités pour combler les lacunes restantes en matière de vaccination. Ça, c'est pour Dr. Benito Ipuma.
Merci beaucoup. Et effectivement, Can I continue? Okay. Merci beaucoup. Merci beaucoup. Et effectivement, le rapport montre qu'il y a un certain nombre de gaps en matière de couverture vaccinale des enfants n'ayant pas reçu aucune dose. Mais ce qu'il faudrait reconnaître ici, c'est que des progrès ont été accomplis. Quand on a eu la pandémie de COVID-19, le nombre d'enfants zéro dose avait augmenté. Et après COVID-19, du fait des actions qui ont été menées, on a observé une réduction des enfants zéro dose au niveau au niveau des pays de la région africaine. Ce qui reste à faire en ce moment, c'est primo la capacité à identifier au niveau sous-national ces enfants zéro dose. On ne se limite plus juste aux couvertures vaccinales moyennes qui sont rapportées au niveau national, mais on porte une attention particulière au niveau de la réponse à un niveau plus sous-région, à un niveau provincial ou au niveau district. C'est là où se trouvent ces enfants-là. Et donc, l'OMS en ce moment, en travaillant en étroite collaboration avec les pays, s'attelle à s'assurer que au niveau sous-provincial, au niveau district, on peut être en mesure d'identifier ces enfants-là, de les vacciner afin de réduire ce nombre de zéro dose. Je voudrais également souligner la nécessité, je pense que Dr Dianabi l'a mentionné, la question de zéro dose n'est pas seulement une question liée à la vaccination, c'est aussi une question liée au système de santé qui doit être suffisamment robuste pour atteindre dans les endroits les plus reculés des enfants qui n'ont pas forcément accès au système de santé. Et donc, c'est une priorité du bureau régional en étroite collaboration avec les 47 pays de la région africaine. Merci.
Merci, Dr. Benito. On reste avec vous. Existe-t-il un risque que la sangle mise sur les nouveaux vaccins détourne des ressources d'autres interventions essentielles contre le paludisme? Dr. Benito?
Effectivement, le risque existe, mais la position de l'OMS est claire ici. Les vaccins antipaludiques ne remplacent pas les autres mesures de lutte contre le paludisme. Bien au contraire, ces vaccins complémentent les mesures additionnelles de lutte contre le paludisme, à savoir le diagnostic contre le paludisme, la prise en charge du paludisme, la lutte antivectorielle. On a de meilleurs résultats lorsque l'on combine les interventions liées à la lutte contre le paludisme. Donc ici, c'est l'occasion de porter à l'attention des médias le besoin d'une approche complémentaire en matière d'intervention de lutte contre le paludisme. On combine le vaccin avec les autres interventions pour obtenir des résultats probants qui permettront, on l'espère, de réduire la mortalité et la morbidité liée au paludisme. Merci.
Merci beaucoup, Dr. Benito. It is now my understanding that Lucia Blanco has a live question. Lucia, please go ahead.
Hello, everyone. Thank you so much for your time. I joined a bit late, so forgive me if what I'm asking has already been commented on. But I wanted to ask about the impact of the current events in the health systems in Africa. We have seen some reports about how the war in Iran has affected the response to cholera. So I was wondering if you could comment on that specifically for cholera and also for other illnesses in the continent in terms of availability of vaccines or other treatments or any other material that might have been impacted. Thank you so much.
Thank you, Lucia. I will call on Dr. Onyango Adelaide to respond. Over to you, Doc.
Yeah, thank you very much, Lucy. Of course, that is a very live concern, the situation in the Middle East. And we haven't yet conducted the kind of analysis that we're able to say this is the scale of the impact on the health systems. But we can anticipate the challenges that are coming and that already are affecting some. As I said, we have not measured them, because as long as we rely on imported products, there is going to be an interference with the supply chains of those products. So that is one area to look at. We know that fuel costs have gone up, and many of our facilities depend on generators to run the cold chain, to maintain services, etc. So health systems, as other systems, are going to be impacted by this. But what we can't put a number of figures to it at this time, because it's still a situation very much in a fluid state. But for sure, health systems will not be spared. Thank you.
Thank you, Dr. Onyango. We have a question from Tosin OG1. The cases of Lassa fever is disturbing in Africa. No fewer than 100,000 and 300,000 cases have been reported for infection, while at least 5,000 death cases have also been reported in Africa. What's WHO doing in helping fight this disease, and what effort is being put in place for emergency response for the victims? Over to you on this one, Dr. Marie-Roseline Belize.
Thank you for the question. So indeed, the Lassa fever is concerning in Nigeria. Maybe I can share some data in order to understand that concern. Since November 2025 to date, so the country has notified 685 confirmed cases. So we also have more than 4,000 suspected cases. And among those cases, the country notified 170 deaths. And those deaths are also very concerning, not only for the global population, but for also the healthcare workers. 42 healthcare workers has been infected, and between them, 5 have lost their life, while serving the population. So Nigeria continue to experience Lassa fever outbreak because each year it is an endemic disease that we have. The endemic, that means it's seasonal. It's still there in a low transmission during some period, and sometimes in the season comes, so we have the peak. And it is with the dry season that we have that peak at the countries. And during usually, for example, the period that came from November to April, as I already mentioned. So we have to know what it is behind Lassa fever. It is a virus that is carried by multi-mammat rat. So which means it's common in rural and urban area and peri-urban area, So where infection are going through food, where the rats are in contact with household item and surfaces contaminated by rodent urine or even jumping. I was in Zambia last year, and I see a lot of, innovation in the community itself on how they are managing to deal with that disease. They show in that conference how they are putting traps for rats in the community. It was really innovative. So, but the recurring outbreaks also show the main drivers of transmission have not yet been sufficiently addressed at community level, but also at national scale. So in many communities, we see that the rodent exposure remain very common because we have weak sanitation. They are the same, I can say, social determinant, economic determinant, political determinant drivers of any outbreaks, as mentioned by the regional director, by my colleague DPC, and also those Lassa fever are driven by this same outbreak. So what we do in order as WHO in order to to support this response in Nigeria, we really work together with the Nigeria CDC in order to strengthen the surveillance. Not only surveillance, but also to give access to those affected to care. We work also with partners like MSF and Alima. We are giving a free treatment to those affected community. We also strengthen access to information, and we support also the country in order to put in place those community protection measures that are through risk communication and information to the countries, so we can reach everyone where it is the disease ongoing. So far, it is concerning because we have 22 on 36 of our local communities that have that reporting cases, but we continue to work. However, it is not that I can say we also have a progress because the epidemic curve is decreasing, and we will continue to work until the end of the outbreak and to maintain the threshold level very low in Nigeria. Over.
Thank you so much, Dr. Marie-Roseline Belize. We do have some last questions, and this one is on polio and security, and it's coming to you, Dr. Ogedi Mohammed. Nigeria aims to interrupt all polio transmissions by the end of 2026. How is the WHO addressing the immunity gaps in insecure and hard-to-reach settlements in northern Nigeria to ensure this deadline is met? Over to you, Dr. Ogedi.
Thank you very much, Tabi. The Nigeria polio eradication strategies is anchored on the Nigeria Emergency Action Plan 2026-2027, which is the time we have for interrupting the polio in Nigeria and overall the Lake Chad region. And based on a few priorities, such as mapping of the settlements, the enumeration of the households, but also based on accountability, partners' accountability, government leadership, and ensuring that the teams are selected based on certain sets of criteria. The program is working on the action plan to make sure that Nigeria is ready for to interrupt the virus by end of 2027. Thank you.
Thank you, Dr. Ogedi. Another question we have still on Nigeria, and this time on malaria strategy. With Nigeria being the highest burden country, how is WHO supporting the enhanced project to ensure that malaria vaccine reaches the most vulnerable children in states like Bauchi and Bayelsa, where uptakes are lacked? This question is to you, Dr. Impuma.
Yeah, thank you very much. In fact, WHO has been closely working with the Nigeria government and other governments across the region to ensure that, one, we provide the required technical guidance to countries on what needs to be done to introduce malaria vaccines, starting with assessing the capacity and the readiness of any given country to introduce malaria. The second one is the capacity building of health workers and then community who supports the introduction of malaria vaccines. The third one, which is linked to this question, is the support to data through what we call the analysis of data to be able to know which within a given country, which areas are making progress, which ones are lagging behind, and which action should be taken to ensure that we can accelerate the implementation of the introduction of vaccines. And lastly, it's really the documentation of progress and the assessment of the impact of the introduction. Just for your information, over the past 27 months, we've evidence shown that malaria vaccines works. In all countries where the vaccine was rolled out, we have seen a reduction in severe malaria cases, a reduction of 13% of all-cause mortality in age-eligible countries. So this is a good story which really encouraged the regional office to closely advocate with governments, advocate with partners to sustain funding for the introduction of malaria vaccines in the remaining countries in this region. Thank you.
Many thanks, Dr. Benito Impuma, for that response. As dear colleagues of the press, we are now coming to a close of this presser. It is now time for me to invite the Regional Director, Dr. Janabi, for a brief closing remarks. Over to you, Dr. Janabi.
Thank you very much, Tabi. So what connects everything we have shared today, immunization, polio, stillbirth, emergencies, is not disease. It is systems. And it is the people. When health systems are strong, mothers do not leave maternity wards with empty arms. Children are protected before disease ever reaches them. Outbreaks are stopped before fear spreads. And communities face crises with resilience, not despair. This is why delivery matters. Primary healthcare, laboratories, surveillance, and rapid response are the difference between life and loss. So as we begin these monthly African-led briefings, we commit to transparency, evidence, and accountability, reporting not only on crisis, but on solutions, on African leaderships in actions, because Africa's health future will not be written anywhere else. It will be built here by African hands in African communities through strong systems that leave no one behind. So we'll see you in May. Thank you very much. Back to you, Tabi.
Many thanks, Dr. Janabi, for those closing remarks. And thank you to all our panelists for that information shared today. Thank you to all of you journalists for engaging with us today in this presser. As Dr. Janabi mentioned, this will be a monthly presser. So looking forward to seeing you again next month. And until next time, it is bye-bye.